Hi everyone, today I'm going to go over the NBME trap deck that I made. This is basically all some of the concepts that I was having a lot of trouble learning. So I thought I could make a video about it. It'll help me learn and hopefully help everyone else learn as well. So question number one is about upper GI bleeding. A 36-year-old woman is admitted for upper GI bleeding. 3 months ago, she was hospitalized for necrotizing pancreatitis. Endoscopy shows gastric varices. So what's happening here? So this is really, really tricky for me because I thought like gastric varices and then necrotizing pancreatitis was from alcohol, but that was not the case. We don't really have to worry about. We don't really. Okay, so basically, what we need to know is with alcohol, um, varices, you'll have them in the esophagus and the gastric varices, whereas if you only have gastric varices, that's when you. So here you're thinking more of there's no sense of liver disease. There's only the only history that you have is necrotizing pancreatitis and isolated gastric varices. So you should be thinking of splenic vein thrombosis. Here, the pancreatitis inflames the splenic vein. Remember how close they are in the body? And this causes isolated gastric variceal bleeding. Whereas in alcoholic cirrhosis, the history and physical exam will have a lot of signs like the bloating, the edema, the spider angioma. Angiomata. So if you see that, you're thinking more of alcoholic cirrhosis. Whereas if you're not having all that history, then remember that the option could be splenic vein thrombosis. The golden rule here is if there's pancreatitis with isolated gastric varices, you're going to think of splenic vein thrombosis. Question number two, an 82-year-old man with known coronary artery disease is admitted to the ICU after an elective colectomy. He has tachycardia, tachypnea, hypoxia, JVD, and expiratory wheezes at both bases. So what's going on here? So he was just admitted to the ICU. So here the answer is congestive heart failure. What should give it away is the JVD and the bibasilar wheezing. This is known as cardiac asthma. And then you also have the post-op fluid shifts in a CAD patient. So this all leads to acute decompensated heart failure. The trap here is if you see that they have a recent surgery in hypoxia, you're going to think immediately PE, but you kind of want to see all the other signs, the JVD, the basilar wheezing, and realize what's really going on is heart failure and not just a PE, or not a PE. Not all wheezes are asthma, not all post-op hypoxia is pulmonary embolism. If you have the JVD and the bilateral lung findings, you want to think of heart failure. Question number three. A 58-year-old woman with squamous cell lung carcinoma presents with pain and tenderness of the long bones of both lower extremities. X-ray shows periosteal new bone formation. So what's going on here? And the answer is the answer is hypertrophic arthropathy from the squamous cell lung cancer. Remember that the lung cancers have a lot of paraneoplastic syndromes associated with them. For squamous cell lung carcinoma specifically, it's hypertrophic osteoarthropathy. I can't say that. Where the lung cancer causes periosteal reactions that leads to long bone pain as well as clubbing that you see in the fingernails. The trap here was if you see lung cancer and bone pain and you immediately think, oh, this must be the PTH, the parathyroid hormone related protein hypercalcemia. But they never said anything about elevated calcium. And then the key clue is the like kind of pathology findings or the imaging findings where it says periosteal new bone formation. This is the paraneoplastic syndrome, not a metabolic one, because you could clearly see it's new bone formation. I should add the image so it's easier to visualize. Next, so This is just a quick graph. And remember that the small cell lung carcinoma has most of the um, paraneoplastic syndromes, whereas squamous cell has like a couple like that we need to know. So I'll add those in as well. And this is a slide just reviewing all of the different paraneoplastic syndromes. This is from First Aid Step 2, so if you guys want to look over all of these, you can do it. Question number 4, a 37-year-old man presents after MVC with seatbelt ecchymosis. Chest X-ray shows an obscured left hemidiaphragm, and the NG tube tip is seen in the left chest. So what's happening here? And the answer is diaphragmatic rupture. So you have this individual who had blunt abdominal trauma, sudden onset increase in intra-abdominal pressure. This led to his stomach herniating into his left chest, and that's why you can see that NG tube tracking into the thorax instead of where it should be, like in the upper abdomen. The trap here is if you see the tube in the chest, you're thinking esophagus problem, which I did, so I got this question wrong 'cause I was like, oh, why would the tube be in the chest? I just didn't think that far into diaphragmatic rupture when I should have. The key distinction between esophageal rupture and diaphragmatic rupture, what is that? So let's find out. So esophageal rupture follows forceful vomiting or endoscopy, like Boerhaave syndrome usually is the one that causes esophageal rupture, not seatbelt trauma. It presents with chest pain, subcutaneous emphysema, and mediastinitis. If the NG tube is in the chest after trauma and the stomach has not moved, or sorry, the stomach has moved, not the esophagus. So the esophagus has nothing wrong with it, especially after blunt abdominal trauma. You want to think diaphragmatic rupture. Question number 5. A 27-year-old man with 6-month history of bloody diarrhea, anemia, and weight loss. Sigmoidoscopy shows pseudopolyps and friable mucosa. The labs show that P-ANCA is positive and ASCA is negative. So P-ANCA is like the P and anti-neutrophilic cytoplasmic something something, and then the ASCA is anti-Saccharomyces. So that's negative. So that tells us that this individual is having ulcerative colitis. Remember that ulcerative colitis is P-ANCA positive, whereas Crohn's disease is usually ASCA positive. So those are the differentiations. So this question basically tells us, hey, it's P-ANCA positive, so for sure this is ulcerative colitis. And just to back it up, ASCA is also negative, so we know for sure it's not, most likely not Crohn's. And that gives us more evidence by showing like the friable tissue, just like with the sigmoidoscopy. So it's kind of telling us like, hey, this disease is limited to the sigmoid and like the end of the colon. And then this is a quick cheat sheet. All right, rapid review. So question number 1 was about pancreatitis and gastric varices. You want to think splenic vein thrombosis, especially if they don't give you all those other symptoms, like from cirrhosis. Question number 2 was post-op hypoxia, JVD with a wheeze. You want to think acute CHF, not PE, which is what I was thinking. Question number 3, lung cancer and periosteal reaction. Remember that there's another paraneoplastic syndrome called hypertrophic osteoarthropathy. Not all bone-related things from lung cancer are PTHRP, so just keep that in mind. Question number 4, trauma and NG tube and chest. You want to think if it's blunt, that's most likely diaphragmatic rupture. Question number 5, if it's P-ANCA positive, you want to think, as well as the colon findings, you want to think ulcerative colitis, not Crohn's. All right, good luck on your exams, and hopefully this helped.